So this is titled "The Cryptic Case of Vision Loss." It was a case that we saw at Ochsner on the retina service last month. And special thanks to Dr. Sheikh and Dr. Benevento for their help. So this is for CME credit. I have no disclosures, and please fill out an evaluation after this. So this patient, kind of going back in time, originally it presented in March 2020. She was a 59-year-old female with a past history of alcoholic cirrhosis and hepatic encephalopathy, breast cancer, status post a lumpectomy and radiation 5 years ago on tamoxifen, and a recent admission for decompensated cirrhosis and bacterial pneumonia. So she, in March, presented to an outside ophthalmologist with painless vision loss in her right eye. She'd reportedly had about 20/40 vision in the right eye before that. And she was diagnosed in March with BRAO. But due to COVID, she was lost to follow-up. And so she presented to us in July. The reason for her presentation actually was hyponatremia, which led her to be admitted. And she had been complaining of some vague sort of nonspecific symptoms, mainly fatigue. Her labs on the visit showed a hyponatremia. She also had a normal white count, and her platelets were low. She was thrombocytopenic. She had a fairly high INR, consistent with her liver disease. Infectious workup was negative. The primary team really didn't have any significant concern for infection at that time. They were just starting her back on some IV saline and gonna treat her for hyponatremia. But she had complained of worsening vision loss in the right eye. And so we got the history, and for her and for her son, understood that she had been diagnosed with the BRAO back in March. She also complained of some right-sided headaches kind of intermittently throughout that time as well. As far as the ocular exam, we found that she was hand motion to projection in the right eye, and in the left eye was 20/20. Her pressures looked good, but in the right pupil, she had a significant APD. Otherwise, her visual fields were also totally deficient, but extraocular movements were still intact. As far as her external exam, anterior segment exam wasn't particularly revealing as far as anything goes. She didn't have any kind of real findings, but when we looked into the vitreous, we noticed that there was, in the right eye, a dense vitritis, too numerous to count, small white vitreous opacities with kind of intervening clear spaces, almost as if it was kind of separated in sheets. She also had like 1+ cataracts. And I would note that her conj, she did have some, I'd say like 1+ icterus as well. It was difficult to really get a good view into the fundus on exam, as her vitritis was pretty thick. And as I mentioned, you could kind of get views through some separated kind of sheet-like opacities, but otherwise you kind of saw some round white infiltrates sort of floating around, but getting a clear view of the fundus wasn't really possible. And the left eye fundus looked totally normal, really no significant findings there. So that led us to get a B scan of her right eye. And so I'll just show you a few images, and then if we could have somebody, perhaps a volunteer, tell us what you see.
Who's going to volunteer? I can volunteer someone.
Okay, I can talk about it. So these are B scans. Kind of in the vitreous, you can see kind of thick white. Kind of, I don't know if it's the retina detaching or like sheets of of fibrinous material coming into the vitreous.
Okay, good. Yeah. So yeah, you're right. This is a B scan of the right eye. The top one is a transverse cut, 12 o'clock showing, you're right to think about that it, the RD, it kind of looks like an RD, but actually with kind of a dynamic exam, it was it was kind of flopping around very easily. That was more consistent with probably like a PVD. And it wasn't really tethered to the back of the optic nerve. And my apologies, you can't really see that from just a couple cuts that I'm showing here. But
you can, Banks, go to the previous one.
yeah, I think you can see it more in that first one. But you can also see some hyperechoic densities consistent with vitritis and some vitreal condensation. Also, you can look at the gain if you're thinking about an RD. And if you look at the A scan underneath, then you can see that it doesn't spike quite as high as you might expect for an RD. So that also kind of makes you think that that might be less likely there. So based on that, what do you guys think we should think about in terms of our differential diagnosis?
Infectious endophthalmitis.
Good. Anything else?
Intraocular lymphoma.
And uveitis.
Okay. Yep. I heard endophthalmitis. I heard uveitis. Any others?
Lymphoma.
Very good.
Okay.
So yeah, you hit on a lot of the big things there. Endophthalmitis for sure. Non-infectious uveitis is another possibility. There's a number of different categories that kind of fall under that, number of different diseases. Also, infectious chorioretinitis is also a possibility. And you mentioned like lymphoma, that's also an important one to think about, just malignancy in general. You could have a foreign body. White dot syndrome possibility, although less likely with the vitritis and everything, but with kind of posterior findings, perhaps. So the objectives for this lecture or for this talk are to review endogenous endophthalmitis, talk a little bit about the pathogenesis, the microbiology, the clinical findings and the diagnostic workup, as well as the treatment, and a brief talk about a piece of literature that I picked out. So in general, endogenous endophthalmitis is responsible for roughly 2 to 8% of all cases of endophthalmitis. So by far, there's more cases of exogenous endophthalmitis, which we'll talk about in a moment to kind of differentiate the two. So it's fairly rare, and it's found to have been originating from sources within the body. And typically in these patients, there's some sort of underlying risk factor. Oftentimes they're immunocompromised. Diabetes is a very common thing that you find among these patients. HIV, IV drug use, kidney failure, IV infusions, or patients that are on hyperalimentation. And it's been shown in some different studies that about 90% of these cases, you'll actually find some sort of underlying risk factor in them. And oftentimes they're older patients as well. The mean patient age is 63. You very rarely see these in children. Not to say that it's not possible, but pretty uncommon. And usually it's one-sided, but about a third of cases have been shown to have bilateral involvement. And it may not start out as bilateral, but it may end up turning into bilateral after initial being in one eye. So just a brief kind of discussion about how to differentiate exogenous from endogenous. So the route of infection is really kind of the determining factor. Exogenous would be something that results from direct inoculation as a complication of some sort of external source, like surgery or ocular trauma, foreign body, or even like a corneal ulceration. But essentially you're having like a breach in the barriers of protection of the eye. So something's coming in from the outside. Whereas endogenous endophthalmitis occurs when organisms disseminate through the systemic, typically the systemic circulation, and enter the intraocular spaces through that blood-ocular barrier. So the pathogenesis, we kind of just talked about it, but you have sort of seeding through the bloodstream that they eventually infiltrate into the retina after reaching the choroid. And then typically from there, they will spread to the vitreous and cause a vitritis reaction that we see, or that we saw in our patient. And oftentimes, due to the kind of this pathogenesis, the embolus and kind of the growth that you'll see will often be kind of close to the retinal vessels. And most common foci of infection that are outside of the eye that lead to endogenous endophthalmitis include liver abscesses, pneumonias, endocarditis, sinus infection, and meningitis. And it's pretty much 50-50 in terms of what kind of organisms you might find. It's between bacteria and fungi, which is pretty different than exogenous, which is typically more bacterial. So the most common bacteria have been shown to be gram-positives, at least in our part of the world. Typically, you find Staph aureus and Strep pneumonia. Those are kind of the two big ones, but there's a number of other ones as well. And amongst the fungi, Candida is by far the most common, and the most common yeast at that as well. And Aspergillus is the most common mold. And in severely immunocompromised patients, like AIDS patients, you certainly want to think about those other more kind of rare atypical organisms such as Crypto or Mycobacterium nocardia. And as I mentioned, you know, in our part of the world, the gram-positives are the more common ones, but if you have a patient coming from East Asia, that may be different. Klebsiella is actually the most common, and gram-negatives have actually been becoming much more frequent, even in the Western hemisphere. So this isn't from our patient specifically, but I just wanted to show a few images of some of the clinical findings that you might see. Could we have a volunteer discuss the top image there?
I can mention it. So it looks like the external color photo of probably the right eye. Just looking from the outside, lids look normal. On the conjunctiva, though, there appears to be injection, most prominently nasally and temporally. Not really perilimbal, though. Can't really tell if there's much chemosis. Looking at the cornea, I can't really evaluate too much, but there's no apparent haze. There does appear to be a small hypopyon, though, just maybe less than 5% or so. And aside from that, iris looks normal. Maybe there is some nuclear sclerotic change, but yeah.
Yeah, very good. Yeah, I think the main thing that I was trying to get you to see was the hypopyon, which in this case is fairly small. Anyone want to talk about the bottom left image?
So it's a right eye, a fundus photo. The media here looks pretty clear. The disc looks nice, sharp. The vessels look normal. In the macula, there's about a half of a disc diameter size yellow lesion that appears flat from the picture, right around the fovea.
Good, yeah, and yeah, I think you said it very nicely. And the disc and the vessels appear pretty much normal. It doesn't look like there's any significant haziness of the vitreous, so no apparent vitritis, but definitely kind of a creamy colored lesion there in the macula near the fovea. And then the other two photos, I was just, the middle one here shows a similar fundus photo, likely of the right eye, with pretty hazy opacity, likely representing vitritis. And I wanted to show the kind of creamy colored vitreal opacity there, kind of a fluffy white opacity. And that's actually a picture of, I believe it's Candida in the eye, or Candida endophthalmitis. And then in that bottom right one as well, that's similar findings, but just wanted to show that's kind of what they call a string of pearls sign, and that you kind of have a lineup of kind of fluffy vitreal infiltrates. And that's also pretty common in Candida as well. So we've gone over some of the clinical findings, but commonly you'll find pain, eyelid swelling, floaters, reduced visual acuity, conjunction, corneal edema, hypopyon, AC cell, and vitritis. You may even see like iris microabscesses. In the fundus exam, we just talked about a bunch of them, but like white infiltrates originating in the choroid that can erupt into the vitreous cavity. Those are often key diagnostic findings. You may see some intraretinal hemorrhage as well, and possibly necrosis if maybe there's been a blockage of a vasculature. Oftentimes, fungus is associated more with the insidious onset, whereas the bacteria may suggest, maybe be suggested by more of an acute onset, but that's not necessarily kind of a hard, fast rule that you can cling to. So as far as diagnostic workup, there's a number of important tests to get. Typically, pretty much in everyone, you'll want to obtain some sort of ocular fluid. Typically, vitreous and aqueous should be obtained. You probably want to run these for gram stain in cultures, fungal stains in cultures, and maybe even PCR if you suspect a viral etiology. And blood tests, you should also get cultures. You may also want to do like liver function tests, checking to see if maybe there's any kind of infection that's involving the liver, and also some of the medications that we'll be putting people on are very harsh on the liver, so you may want to get that anyway. There's a lot of different kind of systemic tests that you also may want to run depending on the patient, kind of depending on the clinical scenario. And imaging is also pretty valuable. As you saw, we got a B scan in our patient because the visibility was pretty poor. But you may consider like a TEE if you think someone has endocarditis. A chest x-ray might be valuable for someone who has possible pneumonia if you don't know where the source is. MRI brain and orbits if maybe they have sort of meningeal signs or signs of meningeal irritation. So oftentimes if you're not sure, or if the primary team is not sure where the primary source of the infection is, then you kind of have to do a pretty broad systemic workup. So treatment typically should begin as soon as you suspect endogenous endophthalmitis. You don't really want to wait for the cultures to come back. So it's really a clinical diagnosis at first, and you should begin empirical treatment while you're waiting the culture results. So treatment should include an intravitreal antibiotic, likely hospitalization, likely you need to discuss with infectious disease to help coordinate systemic antibiotics as well as possibly antifungals, and then also thinking about doing a vitrectomy. So as far as intravitreal therapy, you can think about kind of two different categories, whether you want to treat for bacterial or fungal or both. Typically for bacterial, you'll see ceftazidime and vanc are both kind of the most common, but amikacin and also clindamycin can be alternatives for penicillin allergic patients. And also, I've heard that clindamycin or amikacin can be very actually preferred in the case of a bacillus infection or in the case of like an intraocular foreign body. And in the case of fungus, amphotericin B kind of seems to be the most common option, but voriconazole is also a very good option as well. And when you are doing intravitreal therapy, typically you want to monitor daily for treatment response and then kind of reassess. And if after a couple days they're not doing better, or there's worsening inflammation, or their visual acuity is getting worse, then you may want to consider giving another injection, or maybe even consider vitrectomy. As far as systemic therapy, typically I think this will be done in coordination with infectious disease, but just to kind of gain some familiarity. As far as the bacterial choices, fluoroquinolones can be a really good option. They have very good ocular penetration, particularly moxifloxacin and levofloxacin have been found to be very good with that. But there's other options too, like aminoglycosides. Third generation cephalosporins have good gram-negative coverage as well, and clindamycin and IV Vanc. IV Vanc, you should note that does not have great ocular penetration. And as far as fungus goes, amphotericin B with or without flucytosine is a very common one. But you should consider if you start someone on amphotericin that the ocular penetration is not great, so you may want to coordinate that with intravitreal injections, and also it can be quite harsh on the kidneys and also the liver. So other antifungals include like oral voriconazole or fluconazole. And for aspergillus, voriconazole seems to be the best drug of choice. So I wanted to go over an interesting article that I found regarding endogenous endophthalmitis, and mainly kind of what it indicated as far as vitrectomy and the findings that they had. So this was a study that came out in 2014. It's a systematic review of about 342 cases of endogenous bacterial endophthalmitis. So essentially what they did was they did a literature search through PubMed and various sites and found 342 cases that had been reported and written up and published between 1986 and 2012. The cases had to have clinical features of endogenous bacterial endophthalmitis in the absence of any other cause of inflammation within the eye, in addition to lab evidence of infection. So they had to have like a positive culture, gram stain, or PCR. But the mean age they had out of all these patients was 52 years, and about 60% were found to have predisposing medical condition. You will note that this was only for bacterial endophthalmitis, so it didn't include any kinds of fungal endophthalmitis. But what they found was when they compared people who got vitrectomy and intravitreal antibiotics, when they compared that group to intravitreal antibiotics alone, they found that 45% of the people who got both vitrectomy and intravitreal antibiotics retained at least 20/200 vision, compared with intravitreal antibiotics alone, who had only 25%. So that's almost like a twofold increase, which is pretty significant. And kind of along the same lines with when you compare the vitrectomy and the antibiotic group, they had only a 9% chance of getting requiring evisceration or enucleation, compared to 26% in the intravitreal antibiotics alone. So pretty significant differences there. And kind of just in general, it seems to be indicated in cases of prominent vitreous involvement showing progressive disease despite intensive treatment. The idea is that it may help decrease the load of infection and provide better accessibility of intravitreal medications. Unfortunately, in the case of endogenous endophthalmitis, there hasn't been a whole lot in the way of really strong research, likely because it's so rare and probably hard to run like a prospective randomized trial on. But in, the EVS study is kind of the famous endophthalmitis study, but that focused more on exogenous endophthalmitis that was post-cataract and IOL surgery. So really kind of further studies may be needed to really fully understand what the best kind of path forward is in terms of vitrectomy and endogenous endophthalmitis. But another thing that the study took a look at was the various causative bacteria that were found in all of these cases. And you'll see a pretty widespread between gram-positives and gram-negatives. As we mentioned before, Staph aureus and strep pneumo are some of the more common gram-positives, but Listeria and Nocardia are certainly possibilities, as well as Bacillus cereus. And then there's also quite a few gram-negatives, particularly Klebsiella seems to be a big one to think about. And I just wanted to mention this slide too, because this was another one from their study. And it just kind of shows the breakdown of clinical outcomes in patients, showing their different visual acuities. So it shows the y-axis is the percentage of patients, and the x-axis is the visual outcomes, as well as whether they needed an evisceration or enucleation, or if they died. And so the study was actually broken down. Originally, it was a study that was done only between, 1986 and 2001. And then they added on a second portion of the study between 2001 and 2012. So that's why you see the two first bars in these rows, the black and then the light gray. And then the dark gray is actually when they pooled the results together. So that represents kind of the full cohort. But you'll see that quite a few patients end up with no light perception, or certainly below hand motion, and quite a few end up with evisceration, enucleation, and also some, unfortunately, it leads to mortality. So kind of just reiterating that the visual outcomes in endogenous endophthalmitis are generally poor. Certain factors seem to be associated with better or worse prognoses. It seems like yeast are often associated with better outcomes, whereas bacteria are more moderate and molds are actually the worst. Delay in treatment and low IOP, as well as initial VA of LP, severe hypopyon and absent reflex are all associated with very poor prognoses. And unfortunately, vision of count fingers or worse is often reported in about 41% of cases. And of course, as we mentioned, the mortality rate can be high in these cases. So going back to our patient, we decided to do an aqueous tap and a vitreous tap and injection with Bank, ceftaz, and voriconazole. We sent samples for potassium hydroxide prep, a gram stain, aerobic cultures, anaerobic cultures, and fungal cultures. We got ID on board. And since she didn't have a clear source, a broad infectious workup was taken on. ID decided to start her on PO fluconazole, and our aerobic and fungal cultures returned positive for yeast. Extra points to anyone who remembers what this particular yeast is. Anyone?
Cryptococcus.
Yeah, good job. So Cryptococcus, yeah, and if you recall, this isn't East India stain, I believe is what it's called, but they're kind of defined by their thick capsules. So we got that back and sent after that for a bunch of fungal markers, including Cryptococcus antigen, histo, blasto, aspergillus, and fungitil. We also got a non-contrast CT chest and MRI of the brain. So her blood and CSF returned back cryptococcal antigen positive, and her chest CT showed scattered pulmonary nodules. Her MRI brain came back concerning for meningitis. She had a cystic structure in the posterior fossa that was likely a cryptococcoma. So she was started on amphotericin B and flucytosine for infectious disease. And we gave her another round of intravitreal injection, this time with amphotericin. And then actually 5 days later, we ended up giving her another one. Unfortunately, her VA remained in hand motion, and her ocular exam was essentially unchanged. So we then went on to schedule her for vitrectomy, but she became increasingly encephalopathic and had worsening kidney injury, likely because of all the harsh medications we've been giving her, and also probably like a hepatorenal involvement as well. So she was transitioned to comfort care by the son because actually, unfortunately, she had been declined for a liver transplant, which was something she had been trying to get for some time. So she ended up being discharged home with hospice. So ultimately, the cultures came back growing Cryptococcus gattii, which is a pretty rare organism in general, and also pretty rare in terms of endogenous endophthalmitis. Just kind of a brief overview of it, but it's a yeast very closely related to Cryptococcus neoformans, and typically found in the tropics and subtropical regions. And it's actually more common in immunocompetent people, or more frequent than Cryptococcus neoformans. And but like neoformans, it has a predilection for the lungs and also the meninges. Intraocular manifestations include things like vitritis, choroiditis, chorioretinitis, and exudative RD, as well as neuroretinitis and, of course, endophthalmitis. It may be associated with a prior pneumonia, which in our case, our woman had had a bout of pneumonia back in about February. So, you know, I kind of have a hunch that perhaps things had started maybe around that time. And typically it's best treated with amphotericin B. And when it comes to Cryptococcus gattii in North America, usually it's found more on the West Coast. So finding it here was kind of a weird thing. But I just thought I'd include this picture because typically it's something that is inhaled through the air in the yeast form, and then it takes, kind of sets up in the lungs and then is able to spread through the blood and through the macrophages that it can go inside of, and oftentimes will go to the brain. So looking back to March, she had been diagnosed with the BRAO at that time, and we hadn't had any outside records up until later, but kind of later on through all this case, we ended up getting access to some of the outside records and also getting access to some of the imaging that they had. And this image was one that we found that they had taken from that March visit. So they had diagnosed her with the CRAO, but I think that, you know, we had kind of discussed it and didn't think that maybe it quite matched up with that based on, it didn't really necessarily follow a CRAO pattern in terms of following a arterial distribution of kind of pale retina. Kind of seemed more like a chorioretinal kind of creamy infiltrate to us when we looked at it. But ultimately, this was a time of COVID, and I think that probably that had some sort of factor in it too, and she just had poor follow-up during that time. But some final thoughts on endogenous endophthalmitis is that it may be the initial presentation of systemic infection, especially in immunocompromised patients. So you should always have a suspicion, and if they have any immunocompromised states, that if you find something in the eye, you need to have a certain level of awareness, I guess. And it's a potentially devastating eye infection, so early diagnosis and early management is really important. And this was also an OCT from that visit back in March, kind of showing, looks like kind of a PED with some intraretinal thickening and perhaps a chorioretinal infiltrate. And these are my sources. Any questions or comments?
Sorry if I missed this. For the study, they had like 320 or 330 endophthalmitis, endogenous endophthalmitis cases. Did they like stratify those patients by the original vision like EVS did?
No, I don't think they did. It didn't sound like it. So yeah, I think there's certain biases that could be inherent in that study.
Yeah.
But yeah, good question.
So for the residents, you need to know like the conclusions of the EVS study and like hand motion versus count fingers versus all P, and when you do a tap and inject. But that's all related to, you know, post-cataract endophthalmitis. So.
This was also a long time period from 86 to 2012, and I don't know how much the quality of vitrectomy has improved over time. There might be differences, I'm just saying, with such a long.
Yeah, for sure, good point.
Yeah, and I think one point too is that the antibiotics have changed a lot since then as well. So yeah, it may not be entirely accurate for today's purposes.
So I think one point to stress out is whenever you have these patients with endogenous endophthalmitis and you're working with ID, you need to let them know. I mean, having a patient on a systemic antibiotic or antifungal that doesn't have intraocular penetration is not helpful for us. And most of the ones that do have good intraocular penetration will also treat the systemic stuff very well. So it's important to have a discussion with them. And if they're on Ampho-B, just kind of talk to them and see if the patient can be switched to either fluconazole or voriconazole, and same if they're on an antibiotic that doesn't penetrate, just chat with them and see if they can be changed to fluoroquinolone. Good job, Banks. That was a good review.
Thank you.
Dr. Reynoso, do you care if it's IV versus PO, like to add an additional antifungal with ID? Because if they're already on an IV, maybe the PO would be as good for penetration, or is the IV antifungals better?
I think studies have shown that either IV or PO, as long as the right dose, have the same intraocular penetration. So I don't care. I don't care if it's PO or IV, as long as they have good intraocular penetration.
Okay.
All right, thank you.